All right. Thanks for the introduction, Dr. Gleave. I'm Anthony, for those that may not have met me. I'm one of the R1s, and it's my pleasure today to give this grand rounds on updates in autosomal dominant polycystic kidney disease. I obviously don't have any disclosures. Here are my objectives for the talk today. Now, there are quite a number of them. It may be a bit ambitious, but we'll try and get through all of them. So first, I'd like to start just by reviewing the diagnosis and manifestations of AD-PKD. And from here on out, if I refer to polycystic kidney disease, I'm referring to AD-PKD. Now, there are a number of cystic disorders of the kidney which can be classified into hereditary and non-hereditary variants, with autosomal dominant polycystic kidney disease obviously being a hereditary cause. Now, in comparison to autosomal recessive polycystic kidney disease, which tends to be poor prognosis and present in younger children, often with infant mortality related to pulmonary hypoplasia in utero. That's beyond the scope of this talk. So autosomal dominant polycystic kidney disease is characterized by a bilateral enlargement of the kidneys with multiple cysts of varying sizes. It is the most common hereditary disorder of the kidney, with a prevalence of 1 in 400 to 2,500 births. And it actually accounts for a significant number of patients on dialysis and transplant, with up to 15% of patients on dialysis and around 10% of patients that receive renal transplant. And it does portray a lot of morbidity in later life, with 45% of patients with polycystic kidney disease developing end-stage renal disease by the age of 60. Now, the kidney is the most common site for cyst formation within the body, and a cyst is defined as an epithelial-lined sac which encloses fluid. Now, these cysts in this disorder can develop anywhere along the nephron in a tubular segment from the Bowman's capsule to the renal papilla, although they tend to develop predominantly in the collecting duct. These cysts are characterized by both a proliferation of the epithelial cells lining these tubules, as well as an abnormal secretion of ions and fluid within that expanding tubular segment as a result of numerous growth factors, which can be seen here. And ultimately, it has also been found that patients with AD-PKD have an elevated vasopressin circulating, and that the action of vasopressin may stimulate this increased fluid and ion secretion via a cyclic AMP-dependent process. Given that it's an autosomal dominant disorder, the genetics is quite important here. And the majority of mutations are related to PKD1, which is the most common variant, or PKD2, with there still being about 5 to 10% of cases that are a result of over 200, at least 200 sporadic mutations, which have been described in the literature in patients that may not have a family history. PKD1 is a gene on chromosome 16, and it encodes for polycystin 1, which is a glycoprotein on the cellular membrane. And PKD2, in comparison, is a gene on chromosome 4, and it encodes for polycystin 2. And this is a transient calcium-regulated cation channel. And PC1 and PC2 are intimately related to each other, and they're located predominantly in the primary cilia on the apical surface of these tubular epithelial cells. And the role of this cilia is quite important in maintaining the polarity of these cells, but its role in transmitting information from the tubular lumen into the cell and stimulating further actions is important. Now, classically, the presentation of polycystic kidney disease would present when patients are around 30 to 50, as they develop signs or symptoms related to their ongoing enlargement of the kidneys. However, nowadays, with screening available for patients that have a family history, is probably the most common way that we identify patients these days. PKD1 portrays a worse prognosis compared with PKD2 in that patients tend to progress to end-stage renal disease sooner. Additionally, male gender, onset of hypertension, and earlier onset of complications of the disorder are all related to a poor prognosis. And interestingly, in patients by the age of 40 who have a positive family history for the condition, but are identified to have no renal cysts, particularly on ultrasound, this essentially eliminates their risk of having the disease. Now, I thought this was a useful figure to demonstrate the clinical progression of the disorder with an increase in number of cysts and the size of these cysts across the disease spectrum over time. And the result is that an increase in the number of cysts disrupts the number of functional parenchyma, and that the increase in the size of these cysts, a number of them leads to regional ischemia with further exacerbation of the function of this parenchyma. And this tends to have a snowball effect. And so that you can see that patients with PKD tend to have a preserved GFR until much later stages of the disease when their GFR tends to fall off of a cliff. And in earlier stages, hyperfiltration can be present, which maintains the GFR as a result of the remaining functioning nephrons working harder. Now, the diagnosis is based upon two characteristics: imaging findings of the cysts, as well as family history. In patients that have a positive family history, which portrays a 50% risk of the disease, which is the majority of patients. This is based upon age-dependent criteria. So for those that are between the age of 15 and 29 and have two or more unilateral cysts, or they have bilateral cysts, i.e. one in each kidney, they have the disease. For those that are between 30 to 59, two or more cysts in each kidney, and over 60 who have 4 cysts in each kidney. Now, in patients that have a negative family history, genetic testing is the mainstay for diagnosis. And this can be done via DNA linkage analysis, where they analyze peripheral blood from all family members, or direct mutational analysis to identify specific genes via sequencing. And a presumptive diagnosis can also be made in patients who have a negative family history if they have bilateral renal cysts and the presence of 2 or more of bilateral renal enlargement, 3 or more hepatic cysts, cerebral artery aneurysms, or solitary cysts of the arachnoid, pineal gland, pancreas, and spleen. Now, in patients who have been diagnosed with ADPKD, they should be counseled on the inheritance of the disorder to other family members, as well as related to the potential benefits and potential harms with diagnostic screening, particularly in an international consensus statement around children and young adults. They recommend that if children are asymptomatic, either screening for the manifestations of the disease such as hypertension or proteinuria is equally valid as providing diagnostic testing to these children. An important note from this review was that children who have a normal ultrasound and who are at risk for the disorder does not necessarily exclude the diagnosis. Now, there are a number of extrarenal manifestations characteristic of this of polycystic kidney disease, the most common being hepatic cyst. Intracranial aneurysms are an important part because of 10 to 30% of patients can be affected by this. And this affects the fact that they need to have adequate control of their hypertension in order to prevent aneurysm rupture. In fact, screening for intracranial aneurysms is recommended in patients that have a family history of aneurysm or subarachnoid hemorrhage, previous personal aneurysm rupture history, high-risk occupations such as pilots, or in those who may be undergoing major elective surgery. Particularly transplant patients are recommended to undergo screening. They may have cysts in other organs. Cardiac disease is also prevalent, with mitral valve prolapse being the typical valvular abnormality. Colonic diverticulosis is elevated, as well as pancreatic and biliary dilatations. Now, when the urologist is usually involved with the renal manifestations of the disorder, this ranges from the decline in kidney function with CKD or end-stage renal disease. It's quoted that GFR decline in PKD1 patients tends to be about 4.4 to 5.9 units per year. Patients can also develop hypertension, episodes of pain, both acute and chronic. The chronic pain being more a result of renal capsular distension related to the size of these cysts. They may present with early satiety due to the significant size of these kidneys within the abdomen. They may have nephrolithiasis, and they're at increased risk for this. Urinary tract infections and infections of the cysts, as well as they may present with hematuria. So moving on to our next objective, I would like to discuss some of the literature around the risk of malignancy in polycystic kidney disease. There's been an interesting review which draws similarities between the disorder and cancer based upon some of the hallmarks of cancer, particularly the abnormal proliferation of cells that's closely involved with the mTOR cyclic AMP pathways within these cells. However, polycystic kidney disease cells do not tend to have a characteristic of migration, or which would be a characteristic of cancer with metastases. Now, the underlying findings that may suggest has led people to wonder whether there's an increased risk of malignancy in polycystic kidney disease is the finding of epithelial hyperplasia on histology. And this is a hyperplasia of the epithelial cells lining these cysts, which manifest as micropolyps, as you can see in the scanning electron micrograph on the right. This epithelial hyperplasia is thought to be a result, really, of increased mitogenic factors such as abnormal electrolytes and hormonal stimuli, as well as additional growth factors. And the reason that this is relevant is that it's also found in other renal cystic conditions that do have a known elevated risk for malignancy, including acquired renal cystic disease, VHL, and tuberous sclerosis. So having a look at some of the clinical data on the risk, I would like to review some of the papers, although the results do tend to be mixed, and there are few. In 2009, Haj et al. Presents a retrospective series of 79 patients who had both polycystic kidney disease and end-stage renal disease that received nephrectomy for an indication that was not malignancy, predominantly pain-related. And they found that in these specimens, there was an 8.3% rate of renal cell carcinoma, all of which were T1 stage. They didn't have a comparator group within this study, but they compared their results to those of Denton in 2003, where they found that 4.2% of patients who had nephrectomy prior to transplant that also had end-stage renal disease, which they deemed as an appropriate comparator, was 4.2%, so it appears to be significantly higher. But it's difficult to draw conclusions from this particular study given the retrospective and nature. Now, in 2014, Wetmore et al. Published their data looking at the Scientific Registry of transplant patients in the United States, assessing new cancer incidence in patients, transplant patients from kidney transplant patients who had polycystic kidney disease, comparing those with renal transplant recipients that did not have PKD. Now, they found that there was age and a few other factors that varied between the two groups, so they had to do a multivariable adjustment. But after this, they found that the risk of kidney cancer was actually lower in the transplant patients who had polycystic kidney disease compared with those that did not. And this was statistically significant with an adjusted incidence rate ratio of 0.7. However, one of the limitations of this study is based on this registry, they don't have information about whether patients received a nephrectomy possibly prior to transplantation, which would be an important piece of information given that they would not be at risk for developing kidney cancer if they don't have their kidneys. And polycystic kidney disease patients are probably at higher frequency of receiving nephrectomy. Now, the most recent large-scale study looking at malignancy and polycystic kidney disease is out of Taiwan by Yu et al., and this was in 2016 in Lancet Oncology. They did a retrospective cohort study based on the National Health Insurance Research Database of Taiwan of all patients with polycystic kidney disease. And they found 4,346 cases, and they compared this with the same number of propensity-matched controls that did not have polycystic kidney disease. Importantly, however, they did exclude for patients that had CKD and end-stage renal disease, which are known risk factors for renal cancer. And this obviously plays a large proportion of patients that have polycystic kidney disease who are excluded. The mean follow-up in this study was 3.7 years for polycystic kidney disease patients and 4.9 years for those that did not have PKD. Their overall results, however, suggest that there's an increased overall risk of malignancy for patients with polycystic kidney disease with an adjusted hazard ratio of 1.83. This was statistically significant. And on subgroup analysis by the types of cancer, they found that kidney, colon, and liver were all at an increased risk, which is interesting given that colon and liver are the sites of extrarenal manifestations within the disease. However, overall, it's the limitations of the study, the fact that they've excluded patients with CKD and end-stage renal disease, which are obviously going to be at different prevalences among those with polycystic kidney disease. Does limit some of the information, but this appears to be the most recent data on this topic. So in summary, we really don't have high-level evidence to assess the malignancy risk, and some of the results appear to be mixed. But based on the most recent study, it does appear that patients with PKD may be at an increased risk of kidney, liver, and colon cancers. And this may be a result of the underlying biology of polycystic kidney disease, which does have some similarities to cancer. However, at present, there are no recommendations for screening for malignancy in patients that have ADPKD. Now, my next objective is to look at some of the literature on medical treatments, which tend to be the domain more of nephrology, but I thought it'd be relevant to this talk. An important place to start is in the measurement of total kidney volume, which is performed using an ellipsoid formula seen here. And the importance of this is that total kidney volume is quite a sensitive marker for disease progression in ADPKD. It's known to increase over the course of this condition. And the limitations with measuring GFR is that it may mask the true loss of functioning nephrons due to the presence of ultrafiltration, which I discussed earlier. And therefore, there's been a classification, the Mayo classification, which has been developed to assess the future risk for decline in GFR, and it's seen in the bottom right here to classify patients based on their size at a given age. And a recent paper out of the nephrology and radiology department, actually at St. Paul's, Bevilacqua et al. In 2019, they typically total kidney volume is measured by MRI, but they showed in their study that ultra-low dose CT can be used in place of MRI when not available. And this review here just demonstrates the typical increase in kidney volume over the course of the disease, which can be quite significant. And on the right, we see here that those that have a higher growth rate of total kidney volume are at a higher risk for decline in GFR. So total kidney volume has been an important endpoint of some of the clinical trials to assess disease modification within this cohort, in addition to the change in eGFR. Now, there have been a number of therapies investigated, and I won't have time to go through all of them, but just wanted to provide a summary here of this table showing that a number of studies have shown an impact on the change in total kidney volume growth. But the only medication which has had an improvement in decline in GFR, which appears to be the most clinically relevant endpoint, is Tolvapen, and we'll go through some of this data. Now, the management of hypertension is a core component of management for all kidney diseases to prevent further decline in kidney function and cardiovascular disease. With RAS, the renin-angiotensin-aldosterone system being the main target for these hypertensive management medications, rather. Two high-quality papers out of the New England Journal in 2014, the HALT PKD-A and B studies were performed to assess whether dual RAS blockade with an ACE inhibitor and an angiotensin receptor blocker would have any additional benefit to single-agent ACE inhibitors. Both these two trials were performed in both patients with early-stage PKD and late-stage PKD. And the summary is that neither of them showed a significant benefit to dual agents, and therefore single-agent ACE inhibitors recommended for patients with polycystic kidney disease. mTOR inhibitors have also been a topic of interest within this patient population, given the mechanism of the disease related to this pathway. This was a double-blind, placebo-controlled, randomized control trial out of the New England Journal, evaluating 433 patients who were randomized to everolimus versus placebo, with a primary endpoint of total kidney volume increase at 1 and 2 years. And their secondary endpoint was a decline in GFR. This was a negative trial with neither endpoints being statistically significant. They found that the increase in total kidney volume at 1 year was statistically significant. However, at the endpoint of 2 years, this was not different. And more importantly, rather, the decline in GFR over the trial period was not found to be any different between everolimus and placebo. There's also a very similar study, which I haven't gone through here, that assessed sirolimus in the same year in the New England Journal, and their outcomes were similar with, again, no effect found on change in GFR, total kidney volume. However, the first drug, which has been approved for disease modification in polycystic kidney disease, is Tolvapen, which is a vasopressin V2 receptor antagonist. We know that patients with ADPKD have higher circulating vasopressin levels, and that the mechanism by which vasopressin may stimulate cyst growth and expansion is via cyclic AMP, in which the mediators of cyclic AMP, as shown in this figure, can increase epithelial cell proliferation as well as increase fluid secretion. And the goal of Tolvapen is to block this receptor, the V2 receptor, and ultimately result in a decrease in cyclic AMP. One of the first large-scale clinical trials was the Tempo 3-4 trial in 2014 in the New England Journal, which was phase 3 multi-center placebo-controlled trial of 1,445 patients with polycystic kidney disease, with a in this cohort they were early stage with a GFR greater than 60 and a large total kidney volume. So they're at risk for disease progression. They were randomized in a 2-to-1 ratio to Tolvapen versus placebo, and there was a 3-year follow-up in this trial, with the primary endpoint being change in total kidney volume and secondary endpoints of a composite of clinical progression as well as the rate in kidney functional decline. With their primary, this was a positive trial, obviously, and with their positive endpoint, they found that total kidney volume increased by only 2.8% per year with Tolvapen, compared with a 5.5% increase per year with placebo. And in the forest plot, the subgroup analysis showed that this was a benefit across all subgroups. With their secondary endpoint of change in GFR, this was also statistically significant, with a Tolvapen showing a less decline in kidney function compared with placebo on the measure of 0.98 units. And this was over a 3-year period. Now, one of their other secondary endpoints was clinically significant kidney pain, and this was also found to be significantly different between the two groups, showing that tolvaptan may have an effect in reducing kidney pain for these patients with a hazard ratio of 0.64. Now, tolvaptan is a medication that does have side effects predominantly related to aquaresis, where they present with polyuria, thirst, nocturia, which can be bothersome, as we know. And this led to a higher withdrawal rate from the treatment arm of 23% compared with placebo. There's additionally a risk for liver function abnormalities with tolvaptan, and it's recommended that they be screened while on treatment. But ultimately, the conclusion of this trial was that tolvaptan slows the increase in total kidney volume and the decline in kidney function. There's also additionally a open label 2-year extension trial, the Tempo 4-4 trial, which enrolled 60% of the patients from this current study and provided both treatment arms with tolvaptan. And they showed that over the 2-year extension, that the difference in the GFR between those who had previously been a placebo and those who had previously received tolvaptan was maintained at 2 years, suggesting a longer-term effect. This was a separate study, the Reprise trial, out of the New England Journal again in 2017. And this trial was set up to assess whether patients with later stage polycystic kidney disease may benefit from tolvaptan, given that there's the suspicion that they may not have as great of a role once they've already progressed. This was a randomized, multi-center, double-blinded, placebo-controlled trial. They enrolled 1,370 patients, and the GFR for patients that were aged 18 to 55 was 25 to 65, and patients who were 56 to 65 had a GFR from 25 to 44, and they were assigned in a 1-to-1 ratio to tolvaptan versus placebo. This trial had an 8-week run-in phase, which provided all patients in the trial with an 8-week period of tolvaptan in order to assess whether they could tolerate the side effects of tolvaptan. And if they were unable to, then they were not enrolled in the trial. They were then randomized following this. The primary endpoint was change in eGFR from their baseline to 12 months. Now, one of the interesting initial findings was that tolvaptan actually initially reduced the GFR for patients on the medication in the run-in phase. And there's been some other studies that suggest that this may be via a renal hemodynamic effect with mild dehydration caused by aquaresis, as well as a potential increase in tubuloglomerular feedback, resulting in decreased glomerular ultrafiltration. But that the primary endpoint of change in GFR at 12 months was found to be significant, with tolvaptan having a slower decline in kidney function compared with placebo, suggesting that tolvaptan preserves GFR at a 1-year endpoint, even in later stage PKD. This is just a further study suggesting that there is long-term benefit with tolvaptan. In this study, they enrolled patients with an average follow-up of 4.6 years, and with some patients being followed up to 11.2 years. And the benefit in the GFR slope was less with the tolvaptan group compared with control. And again, you can see here that there are some adverse effects related to tolvaptan use. So in summary, of the medical management for PKD, hypertension is the backbone for treatment with ACE inhibitors, and single agent is sufficient. Tolvaptan, the vasopressin antagonist, is the only disease-modifying agent on the market and is currently approved in the US and Canada, particularly for those who have evidence of more rapidly progressing ADPKD. It may also have an additional benefit of improving pain for these patients. However, one piece of information is that we don't have further long-term data to show that tolvaptan slows the progression to end-stage renal disease, which would again be a long-term outcome, but clinically relevant. And as we briefly touched on, there's no current role for mTOR inhibitors, somatostatin analogs, or statin therapy in the management of PKD.
Anthony?
Hey.
Just a quick question. Did you run into what the current cost of Tolvapen is in Canada? Just because
yeah, sorry.
A couple of years ago, when it was reviewed, I believe the cost was upwards of even $300,000 a year. So that was one of the major issues.
I did have the cost for it in, let's see. I had it in the United States, but I can't recall what it is for patients in Canada. Sorry.
But just be a major consideration, because going forward, if these patients are started on it at a relatively young age and for essentially their lifetime, that's a significant cost, and it's not known whether or not long-term use would necessarily change the progression to end-stage renal disease. So that's just a consideration.
Yeah, thank you for bringing that up. Now, the next section I would just like to touch on are some of the surgical managements for complications of polycystic kidney disease, which is when urology is more likely to be involved. Now, the complications that we'll discuss here have to do with pain, cyst infection, as well as nephrolithiasis. For the management of pain, there have been a number of different methods that have been explored in the literature, with renal denervation and cyst aspiration sclerotherapy being, as well as cyst decortication being shown in the literature. However, a lot of this literature is really small case series, and so I've chosen to focus on cyst decortication. Dr. McDougall described cyst decortication back in 2000 in the Journal of Endourology with patients who have ADPKD, and suggested that this can be done laparoscopically, but that it's important to completely mobilize the entire kidney and treat every visible cyst. She even suggests using an ultrasound probe to find all the cysts within 5 to 10 millimeters of the renal surface, such that they can be unroofed. The literature around cyst decortication, however, is quite weak. There's a systematic review done in 2013 by Miller et al. And they looked at the 18 papers that they could find in the literature. And as you can see, the majority of these papers were done quite early in the 1990s, and that the number of patients in each was quite low. However, the primary indication for cyst decortication in the majority of these trials was predominantly for pain. And they found that overall, there was durable pain relief for those who received cyst decortication, but particularly they had to be a specific patient population that had chronic pain or early satiety, which could be related to the cyst size. And these were patients that typically tended to have dominant cysts found on imaging or quite large kidneys. However, they found that amongst all these studies, there was no improvement in hypertension with cyst decortication, and that there was no improvement in their renal function either. However, importantly, it didn't appear to have a negative impact on their renal function as well. Now, cyst infection can be a diagnostic and management dilemma for those involved. It can be quite difficult to diagnose. And cyst infections tend to be most commonly ascending from a urinary source, although some reports suggest hematologic is possible as well. They should be treated with lipophilic antibiotics so that they can penetrate the cyst. And reviews suggest that a longer duration of antibiotics is often required. There's a systematic review here from 2017, which evaluated 60 papers in the literature on cyst infections. And they found that across all these studies, there was only 85 patients that they can include in this analysis. And they found that patients who had success with antibiotic therapy alone tended to have a median treatment course of 28 days in comparison to those who had failure with only 7-day course. However, that may be a result of them progressing to further intervention sooner. They also found that renal cyst infection in polycystic kidney disease patients was associated with a high rate of failure, with 50 to 75% of patients requiring further percutaneous or surgical management. And in the table here above, they've differentiated the studies from those that were performed before 2000 and after 2000, showing that percutaneous management was more common after the year 2000, which would be a more contemporary approach. However, still 30% of patients required a final therapy, which was surgical, including a nephrectomy. This was a single center retrospective review of their cohort of polycystic kidney disease patients who had infected cysts, both of the kidney and also of the liver. And I tried to look through just the data here that was related to kidney and cyst infections. They found that E. coli was present in 74% of these infections for those that had positive cultures, and that the mean duration of antibiotics in their patients was 5 weeks. However, it's important to note that the diagnosis is quite difficult, given that blood and urine cultures can often be sterile. And so the clinician requires other further information to make the diagnosis. In their study, they differentiated patients who had a definitive diagnosis, which was required to have cyst aspiration for diagnosis, or patients that had a likely diagnosis based on the presence of fever, flank pain, and an elevated CRP. Now, when they looked at the type of imaging which was provided the diagnosis for cysts, they found that PET scan actually had the highest sensitivity, but it's important to note that only 4 of these patients of 29 received the PET scan. In all 4 of them, this appeared to contribute to the diagnosis. However, when they compared that with conventional imaging, those results tended to be worse. Now, when I thought this was an interesting point because obviously there's significant limitations with access to PET scan, and in other reports focused on this, it appears that the sensitivity may be more in the range of 65 to 75%, but that there may be a small benefit to PET scan in these to help with the diagnosis for infected cysts. In this particular paper, 4 of the 29 patients ended up requiring percutaneous drainage for management, and 2 of them actually required nephrectomy. Now, nephrolithiasis is also an increased incidence for patients with polycystic kidney disease, 5 to 10 times greater than that of the general population, with an incidence of 20 to 28%. The diagnosis should clearly be made based on a CT-KUB, given that there are limitations with ultrasound in polycystic kidneys. And the higher incidence of nephrolithiasis in these patients is likely related to both anatomical and metabolic factors, with the anatomic factor being the compression of the pelvic ileocecal system by these cysts, which can lead to urinary stasis and increase their risk for urinary tract infections. The most common metabolic abnormalities in patients with the polycystic kidney disease include hypocitraturia, hypomagnesuria, which are important stone inhibitors, aciduria, with a majority of patients with polycystic kidney disease being found to have a acidic pH less than 5.5 rather. And this portrays their increased risk for uric acid stone formation compared to other patients, non-ADPKD patients. And they also tend to have a lower urine volume. So given these metabolic abnormalities, it's recommended that all patients who have polycystic kidney disease and develop kidney stones should receive a metabolic evaluation to prevent future recurrence. In terms of the management of stones in this population, generally they really should be managed quite similarly to other patients who do not have the disorder. Some papers suggest that a more prompt management should be obtained in these patients, given that we know there are increased risks for future GFR decline. However, there's no specific evidence that our contemporary management methods should differ in those who have polycystic kidneys. Some of the theoretical risks related to shockwave would be that of a cyst hemorrhage. However, this has not been borne out in the literature, although it is quite dearth. There's also can be a challenge with percutaneous nephrolithotomy with obtaining access due to the number of cysts and the distortion of the renal calyces. These are really the only two studies that specifically address shockwave in polycystic kidneys. From 1997, this paper followed only 16 renal units that were treated with shockwave, showing an adequate stone-free rate of 85% over 3 months, and that only 2 patients received a second shockwave treatment. They reported no complications, particularly no occurrence of cyst hemorrhage. In 2002, a similarly small study evaluated patients who had stones and renal cysts, and these were both solitary multiple renal cysts as well as polycystic kidneys, with only 4 patients with polycystic kidney disease. The overall stone-free rate in this population was 60%. However, for those with polycystic kidneys, again, only 4 patients, they showed that 25% of them had a stone-free rate based on KUB and ultrasound at 1 month. But it's really difficult to base any clinical decisions based on the small numbers of these studies. Now, with regard to percutaneous nephrolithotomy, there have been a few studies that have looked at that within the PKD population, which I've tried to summarize some of the relevant information here. Again, they're plagued by low study numbers, but overall, it appears that the stone-free rate on initial therapy of between 70 and 90% does seem reasonable, and that the complications, although they vary between studies, also appear to be reasonable, with the embolization rate being quite low. And there also doesn't appear to be any significant detriment to kidney function following PCNL. So it appears that it is a option for these patients. So to summarize some of the information we've gone through for surgical interventions, there appears to have relatively weak evidence to support laparoscopic cyst decortication. However, it does appear to have some improvement in more size-related symptoms, so pain or early satiety, but not for improvements in hypertension or decline in GFR. Cyst infection can be a difficult diagnosis and management dilemma for the urologist when involved, and they may require intervention for persistent or recurrent infections, with a preference towards percutaneous approaches before surgical. And finally, nephrolithiasis appears to be managed similarly in patients who have polycystic kidney disease. Now, with the remaining time that we have, I would like to review some of the considerations in renal transplant for polycystic kidney disease. An important point here is that patients who are undergoing a evaluation for living-related donors, their related donors should be screened for polycystic kidney disease to prevent the possibility of transplanting someone, from removing a kidney from someone who may have the condition. And if there's any doubt in the diagnostic screening modality, that genetic testing should be performed. Prior to transplantation, all PKD patients should be evaluated, and particularly they should be screened for intracranial aneurysms, which we reviewed previously. Now, it's quite controversial, the role of native nephrectomy, but the literature really is leaning towards leaving the native kidneys in place, if at all possible, to maintain residual diuresis. And this is especially important for patients who may be pre-transplant on the waiting list, given that this could delay their need for dialysis. However, there are some indications for native nephrectomy if these are for insufficient space of the graft, for recurrent bleeding or recurrent cyst infections, for symptomatic and recurrent kidney stones, for severe pain or early satiety, which cannot be managed by other means, and or suspected malignancy. One point I wanted to bring up here was that following transplantation, the native polycystic kidneys have been shown to tend towards regression in the size and volume. This study here shows that the mean reduction in total kidney volume was up to 45% at 6 years in these patients, and that the reduction tended to continue over the follow-up period of this study. And you can see here in this diagram, in this figure, that the improvement in cyst volume can be quite drastic following transplantation. So for those patients who maybe have more mild symptoms, it would be quite reasonable to watch them, and following transplantation, they may have improvement in their symptoms and avoid the morbidity related to nephrectomy. There's a lot of controversy around when native nephrectomy should be performed in patients that have some of these indications. Some authors suggest it can be done before transplant or after transplantation. There's a sandwich technique described where one kidney may be removed prior to or at the time of transplantation, particularly for those maybe who have space considerations, and the following kidney can be removed after if necessary. However, there has been a lot of focus on whether simultaneous native nephrectomy can be performed at the same time as transplantation via an open or a laparoscopic approach, and that this may avoid multiple operations for these patients and prevent the need for dialysis in some of them for preemptive transplants. This here is a retrospective study looking at simultaneous nephrectomy of at the same time as living renal transplant, comparing 66 cases with 52 who had living renal transplant alone. And it's important to note that the nephrectomies, which were performed via an open midline incision. Here you can see that the main indications for nephrectomy in this cohort was predominantly pain and early satiety, and that other complications were less common. Looking at their operative details, we can see that there is quite a significantly increased morbidity related with the combined approach. Their operative duration was significantly longer. Estimated blood loss was quite a bit larger, up to 3 times the amount, with 1.2 liters being the mean. And this was related to the fact that patients also required a higher transfusion of packed red blood cells in 90% of patients that underwent a simultaneous approach, compared to 23% who underwent living renal transplant alone. And that, as we know, increased transfusion rates in these patients can cause sensitization and make it more difficult for them to match kidneys in the future if they require a second transplant. So these are considerable morbidities. They also found that the length of stay for the simultaneous procedure was longer than for those who had living renal transplant alone. And as you can see here on the right, there were also significant intraoperative complications for the simultaneous procedure, with IVC and renal artery injuries, splenic injuries, and liver injuries being present. And 2 patients within the simultaneous cohort actually required re-exploration, being brought back to the OR for a second procedure to control bleeding. However, given all of that, the authors concluded that a simultaneous approach may be feasible, and that they do have good short-term results at 1 year with a graft survival rate of 100%, despite the fact that there's a significant early morbidity with this procedure. Finally, there's a second study here that I'd like to review, which looks at laparoscopic bilateral nephrectomy with simultaneous transplant, compared against bilateral native nephrectomy in patients who underwent a transplant either before or after their nephrectomy. The characteristics of those who underwent a simultaneous approach are shown here on the left, with the predominant indication being for pain again. And the majority of these were living donors, likely for scheduling reasons. However, when we look at the results of these two cohorts, we have to take into account that the staged cohort here, their operative details reflected both operative settings, whereas the simultaneous was just the one. But it showed that in this study, with more reasonable operative outcomes, the operative duration was quite similar. Estimated blood loss was the same. And however, the length of stay for a staged approach, again, considering that they had 2 separate procedures, was longer than for a simultaneous approach. But overall, they conclude that a laparoscopic native nephrectomy at the time of transplantation is feasible and may reduce some of the multiple operations for these patients. So overall, to summarize, the considerations for transplant in autosomal dominant polycystic kidney disease, we know that native kidneys tend to regress in volume following transplantation, and this may allow patients with mild symptoms to be delayed for native nephrectomy or prevented entirely. Overall, there's a strong push to avoiding native nephrectomy in patients unless they have strong indications for it, and that overall the timing of native nephrectomy appears to be quite surgeon and center dependent, and really does depend on other patient and transplant factors as well. So with that, I would like to thank Dr. Harriman and Dr. Eng for their time in reviewing my slides prior to this presentation and discussing it. And we will actually be looking at a retrospective cohort of our polycystic kidney disease patients here at UBC and be publishing on this in the future. So I look forward to working with them.